Student. We just have to say hello to you, Kelsey.
Good morning. Pleasure to be here.
Well, we're so happy to hear you. Have you enjoyed working with Dr. Ellsworth?
I have. It's been quite a variety.
Good. And you really don't want to be on this, do you? So we're going to let you sit in the background.
I would prefer to listen. Thank you.
She had no idea she was going to be on the radio today.
Yeah. Well, Dr. Holm does that, so I had to do a little bit of it. Yeah. He'll bring students in here, and they have no idea they're going to talk, and he'll talk to them for 10 minutes, and they have to answer all these questions they'd rather not. But we'll just let Kelsey work with you on your regular hours and leave her alone during this. But, I know we talked about doing this program, and you were very interested in screening tests, particularly one. But I thought, before we get to the one test you're interested in, why don't you tell us what medical screenings are?
Well, the whole idea behind screening is to take someone who's not having any problems, really, but to do some tests to try to find cancer before it maybe even becomes a cancer, or catch it early so something can be done about it, so that way it won't disrupt someone's life and being diagnosed later.
And that's the reason would a mammogram be considered a screening? Women get mammograms?
Mammograms and breast exams for breast cancer screening. We've got the colonoscopy for colon cancer screening, and the evidence behind that is wonderful. Pap smears for cervical cancer, and thankfully that's been a big success too.
Okay, and there's one specifically for men.
For men, men have prostates. And the prostate is a small organ the size about of a chestnut, sits just below the bladder, and it naturally gets bigger over time, and it can develop a cancer, prostate cancer. And so I'll be wanting to talk more about that.
Okay. Well, this will be an interesting discussion on PSAs, prostate screening exams, and what I think we should do is take our first break, and then we can really get into this discussion. We'll be back right after these words. Often take a break really the first 2 minutes into the program, but I thought it was good because I know Dr. Ellsworth is really interested in the PSA screening, and to talk about screenings first so people know why you're screened, because you're trying to prevent a disease or if the disease is there before any symptoms show up.
Right. Yeah, I wanted to focus on prostate cancer screening today because it doesn't get as much talk, and it really needs a lot of education because it's not one that we recommend necessarily everyone for sure have. There's risks to screening, and then there's benefits to screening. Going back to the prostate, what good does the prostate do? Well, the prostate basically adds some of the fluid that makes up your semen. And so
that's somewhat important for men.
Yeah.
Yes.
Yeah.
Okay.
It's nice.
Nice to have.
Nice to have. And like we were saying, it naturally can get bigger over time, and that doesn't necessarily mean you have cancer. That's an enlarged prostate.
What would cause it to enlarge if it isn't cancer? Just natural?
Just kind of natural.
Okay.
Yep. We call that benign prostatic hypertrophy, BPH. And there are medications that can be used to help shrink the prostate, and because your urine flows right through it, and so sometimes when it's enlarged, it squeezes and makes it harder to go, harder to start to go, harder to empty your bladder completely, and the medication can help with that. But one thing the prostate does is it gives off this protein called the PSA, the prostate-specific antigen, and that can naturally increase as you get older too. But if you do have some cancer cells in there, oftentimes that PSA becomes even higher. So that's the blood test that we can do to screen for prostate cancer.
So when you do a PSA, you're really doing a blood test?
Correct. Now, if you come in the doctor and they do a digital rectal exam with their finger through the anus, they can feel the prostate, And that's another way you can feel if the prostate's enlarged, if it feels irregular, maybe concerning that there could be a cancer. That's another way to check for that. And that also is a method that we're kind of getting more away from too, not just due to discomfort, but because it's just not a very specific test.
There have been quite a few changes in determining prostate PSA tests in the past, I'd say 5 or 10 years.
Yeah.
You know, for years, you heard every man should get it.
Right.
If you have it, you have to have this surgery. That's all changed in the past few years. And why has that changed?
They've been doing more studies, and they're finding that these tests aren't always as useful as we thought they would be. You know, ideally, if we were screening everyone, then, you know, maybe fewer people would get it and fewer people would die, but we're just not seeing that benefit that we thought we'd be seeing.
Okay.
Now, there's a lot of gray area in there, and that's one reason I wanted to talk about it, to kind of hash that out. So let's take a step back and realize how common prostate cancer is. Basically, 1 in 6 men in their lifetime will get prostate cancer.
That's pretty common.
About over 16%. But the mortality rate from prostate cancer is not even 3%. So it's the most common cancer for men, but it ranks second for mortality, for causing death in men, behind lung cancer. You know, and obviously for lung cancer, the best thing is to not start smoking, but other people can get lung cancer too. So with the prostate, it's so common. If we were to do an autopsy on all 50-year-olds, 30% of them actually would have prostate cancer in there.
But they didn't die.
They didn't
from
know it. They didn't die from it. It wasn't
they
an
died
issue.
from something else.
Yeah.
Right.
When we look at 70-year-olds, about 60% of them would have it found on autopsy. But it, you know, wasn't causing them any issues. In fact, those that get diagnosed with prostate cancer, and if they do nothing about it, 80 to 85% won't have any symptoms after 15 years.
Wow. So you could go to 75 without ever having a symptom, or 65, and my math was off, 65
Right.
without having
Yeah.
a symptom.
So with
Why
that
would you have
said,
the
with that
surgery
said,
then?
I don't want to ignore the fact that prostate cancer is devastating and can become very, you know, it can spread and become very serious and does cause death. And I've had patients, and it's a sad deal. And so then a person's like, well, I want to do everything that I can if I find out I have prostate cancer, and that makes sense. But thankfully, only about 15% of those cancers are the bad kind. The other kind are just so slow growing, they probably won't cause any issue.
Have we been able to find a way to know which is the slow growing and which is the fast growing?
We're still working on it.
Oh, okay. It'd
Yeah.
be nice if we knew that.
You know, they're working on genetic tests. They have found a couple genes that are linked with the bad kind, but they're still working on that. It's not really shown to be helpful in the clinical setting as much yet.
Okay.
And they have free PSA and other forms of PSA that they test that they're kind of working on too. And all that information can be used to kind of decide if you want to do a biopsy. Because let's say you see your doctor and you have the PSA and it's high. You know, maybe it's over 4, maybe it's even over 10 or whatever. There's different cutoffs that you could consider to decide, okay, now it's time to see a urologist to think about having a biopsy. If you have a biopsy, there are some risks with that. I mean, you know, there's pain and discomfort. There could be some bleeding, small risk, you know, of infection or maybe even needing a hospitalization. Thankfully, the long-term risks of having a biopsy aren't so bad. You know, I mean, it's low, the long-term risks. But, you know, since prostate cancer is so common, there's a decent chance they'd find cancer. About at least 25% of people with an elevated PSA, they'd find cancer
They would
in
find
there.
cancer.
Yeah. You know,
So if you
other
would-
reasons that can cause an enlarged high PSA is prostatitis, infection of the prostate. Ejaculation, if they've had sex lately, can actually increase the prostate. If they've been riding horse, things like that could elevate it too.
That's what I was wondering, what would cause it to elevate if it weren't cancer, and those are the causes, huh?
Yeah.
Very interesting.
Yeah.
I think we're going to take our next break, but we hope you continue listening, learning out more about prostate cancer. To Prairie Doc Radio. We're happy to have you listening today. Today, we have as our guest, with Dr. Holmes' absence, Andrew Ellsworth, who is a medical doctor with the Avera Medical Group Brookings. And Dr. Ellsworth is very interested in talking about prostate cancer today. I do know, I wasn't aware of the controversy involved in this screening until you mentioned that you wanted to talk about this. I looked it up. There is a lot of controversy. In your practice, I'm just curious, when do you decide who you give that PSA test to? How do you decide?
When someone comes in for their physical, we're looking at their blood pressure, we're looking at their weight, we're looking at their medications, we're looking at their risk factors. Certainly if someone has a family history of prostate cancer, then we're going to consider that more. We're looking at everything, but one of those is also discussing, okay, do we want to do a PSA and to screen for prostate cancer? And, we can try to dive into some risks and benefits with doing it, but, there's not always as much time as I'd like in the office to discuss it, which is why I kind of wanted to talk about it here.
Oh, good. Okay.
When do I decide? I do leave that up to the patient because it's their call. Most men, do get it done. And, you say to yourself, well, there's really no risk to just having a blood test. I'm getting blood tests anyway. I'm checking their cholesterol and maybe some other tests too. Screening for diabetes with the blood sugar.
These are all more screening tests now, and they're blood tests. Usually the screening are blood tests, but you do a full screening, so it would be very easy to add the PSA blood test to it.
Right, and you could definitely argue there's not much harm done. It's a cheap test, really, but if it's high, then you have to consider, okay, if I'm going to have that biopsy, and then and see the urologist. Now it is something that can be watched. We can just watch it and see where the PSA trends, if it's increasing or decreasing or staying about the same. And that's one benefit to having one done every year or every other year, is you can see if and when it's increasing or how fast it's increasing, and that can be a little helpful too sometimes. And then if you have a biopsy done and you are found to have prostate cancer, once again I want to make the point that it's not a death sentence. There's a good chance this may not cause you any problems. But then again, in the back of your mind, you've got cancer.
The word is cancer.
Right.
That's all you have to hear.
And so, there's a few options of treatment. You could have it surgically removed with surgery, a prostatectomy, where they remove the prostate. You could have radiation done. They have these also another options, these little seeds that they implant that give off radiation to help kill the cancer just right there. And those are fine options and very common. About 90% of men actually usually do something about the cancer if they find out they have it. But at least 50% of those men will end up with impotence and erectile dysfunction.
Which is not a good outcome.
No, it's about a coin flip that'll happen. So that affects your life. And at least 20% will probably have urinary incontinence too, where they might leak urine and have to wear, some sort of pads or diapers or something.
To protect, right?
Mm-hmm.
Yeah.
So
this is not sounding good.
No,
What's the positive on this?
So the positive is that that thankfully a lot of times it's a cancer that we maybe don't have to do anything and that we can just watch. And there's a lot of men that they may find out they have cancer and they decide to just watch it and maybe get checked again, another biopsy in a year or two, or and keep monitoring the PSAs. And I just want to make sure that people are aware is that that's an option. And the other positives are that we're working on it. We're doing more research. There's promising things, like I said, with the genetic tests. So.
Well, Dr. Ellsworth, we mentioned at the outset of this discussion that maybe 10 years ago you didn't give these options. You just said, oh, you have prostate cancer, go to a urologist. The urologist will recommend surgery, and you have the surgery. So you didn't have much choice, and you ended up with no cancer, but some negative outcomes.
Yeah.
Now you want to point out the fact that men do have an option.
Right.
Even if you have prostate cancer, you don't have to have work done immediately.
I was talking with my wife about it, and she kind of felt like, boy, if I found out my dad had cancer, I'd tell him to do everything he can about it. But, maybe that's not always the best solution. It's a fine solution, and boy, then you wouldn't have to worry about it anymore. And so that's why most men are getting screened, and most men are still having surgery or having radiation, and that's working. But we have to screen about 1,000 men and treat all those people that we find with cancer to save one person from dying of prostate cancer. And that's from some studies. I found that other studies didn't find any benefit from doing it. And that's kind of why in 2011, the United States Preventative Services Task Force made the recommendation not to screen. Now, other organizations like the American Cancer Society, the American Urological Association, decided, okay, well, really you should just talk to your doctor and kind of decide together. And that's why we're here talking about it.
Okay, so if a gentleman is screened, his numbers are, tell us the numbers again that we're looking at in PSA.
Generally we think of 0 to 4 as normal.
Okay, if he has a 6, would you, and he doesn't really want to go any further, would you say, I'll see you in a year, and we'll see if it's still at 6, or what would you suggest?
Yeah, that'd be a fine option. And say, should we check? Could depend on if I have a test from the year before to compare to. If it's risen much, or hasn't changed much, is going to depend on what I do. If we maybe check it again in 6 months or a year.
And how high would it be before you'd be really worried?
Certainly if it's over 10.
Over 10, you definitely would suggest a urologist.
Most of the time over, 4, 5, or 6, I'm sending them to your urologist so they can sit down with them and have that conversation.
Okay.
But remember that a urologist is a surgeon, and that's what they do. And this is a $3 billion industry. The PSA
that kind of scary. Medicine, when I was a kid, you just did what the doctor told you. It wasn't your choice. You had no choices. And that was really easy on the patient. Now we've reached the age where we have to make all these choices.
Yeah.
You've made it very difficult on us.
But, that's the benefit of having a family doctor.
It
who
is.
You know and who you trust, and that, is willing to say, I think you should do this, or maybe you don't need to do this. Yeah.
So trust your family doctor. If you don't trust your family doctor, find a new one. But trust your family doctor. We're going to take a break. We'll be back right after these words. Prairie Doc Radio. I really enjoyed this discussion with Dr. Andrew Ellsworth, who is a family practice physician with the Avera Medical Group Brookings. Dr. Holm will be back next week, I think, but we're very happy to have Dr. Ellsworth here because he wanted to discuss prostate cancer. I mentioned this to my daughter. I was just visiting my daughter in Boston. Just got back yesterday. Great time there, but I said, we're going to talk about prostate cancer. You know, there's a lot of discussion that people shouldn't have the screening. She said, well, what's wrong with that, man? I said, what do you mean? She said, well, everyone has to have the screening. And I said, that's the concept that some of us have. We don't know there's a change going on, and there really is a change. Because of research, doctors have found that the prostate screening is somewhat questionable now.
Well, you know, what we recommend, we want to have evidence behind. And when we're finding if the evidence doesn't show that it helps, we're deciding it's not worth the time, it's not worth the cost. With that said, I know there's people listening that were screened with their PSAs, had a biopsy, were found to have cancer, had it removed, and feel like it saved their life. And that certainly could be true.
Certainly. But you just don't know for sure.
Right.
That's the problem. Well, you know, I'm thinking, I'm married to an older gentleman. Somehow that happened. He got a little older. But anyone in their 70s or 80s, do they keep screening them, or you just figure, oh, I couldn't kill him now? When do you decide?
I don't know how far down he robbed the cradle, Joan, with you. But
Thanks a lot.
The general recommendation is to discontinue at age 70, 75. Now in South Dakota, we've got a lot of nice men that live a long time.
Very long
that
time.
are nice and healthy. And there's certainly some of those that I would continue screening in if that's what they wanted to do. And of course anyone if they wanted to. But generally we recommend discontinuing screening really for any type of screening if a person's life expectancy is less than 10 to 15 years. Less than 10 years, especially in prostate cancer, maybe 10 to 15 years, because really in 15 years, even if you had a cancer now that we've detected, chances are it wouldn't affect you in 15
Something else
years.
is going to get you,
Yeah.
right? Not the cancer.
Yeah.
Very interesting subject, interesting discussion. These screenings are fascinating to me. For one thing, I had thought when I reached a certain age, I didn't need to do a mammography anymore. And Dr. Johnston last week really laid it on me.
Oh,
And
okay.
she said, you know what? The older you get, the more likely you are to have breast
true.
cancer. I
Yes.
had no idea.
Yeah.
And I don't know if you want to address that too.
Well, yeah, and that's true for the prostate cancer too. Is as the percentages increase as we get older. The only difference goes back down to that main point that prostate cancer is often slow growing and may not cause any problems, whereas the treatment for it has a higher chance of causing problems.
But for women,
For women, that'd be a different story. I mean, if you had a mastectomy and had the breast removed, granted there is, some consequences or, side effects from that, but then again, you have it removed, you don't have to worry about it anymore.
it's overall much more
know.
beneficial,
Yeah.
right?
Mhm.
Yeah. Okay.
Yeah.
Well, we pretty well covered that discussion on prostate cancer, have we?
Let's recap it.
Let's recap it. Okay, we can do that.
Prostate cancer is very common. We can screen for it with a PSA blood test. The test isn't perfect. It doesn't catch all cancers. Even if it's high, doesn't mean you do have cancer. The cancer is often slow growing, but 15% of the time it can be fast growing and bad. The treatment options are surgery and radiation. Those can cause impotence or urinary incontinence. 50% of the time impotence, 20% of the time urinary incontinence. But then the cancer's gone, you don't have to worry about it. However, 80 to 85% of people, if they decide not to do anything about their prostate cancer, won't have any problems from it in 15 years.
That's amazing. Quite a recap of the subject. Even though you recapped, we have a few more minutes, and
That's
we did
fine.
have one woman.
Sounds good.
I don't know if it was a man or woman, but called in with a question about vitamin D. Wanted to know what do you think is the correct amount of vitamin D to take every day, and do you think a multivitamin is good or separate vitamins are better? She didn't give an age, so I can't give you that.
Generally 1,000 to 2,000 international units a day, probably as a separate vitamin. Granted, you could get by with at least taking a multivitamin. You could see how much is in there. It might have about 800, perhaps only 400 in there, and that might be all right too. If you're concerned about, we can check a blood level of the vitamin D. It is amazing the number of things that vitamin D seems to affect, and has been linked with, including some cancers, multiple sclerosis, and just kind of your energy and fatigue, not to mention it's good for your bones. So certainly any woman past menopause should be taking calcium and vitamin D. I see from the question they were also wondering about seasonal affective disorder, and that's going to be an issue this time of year when it's dark so long. And
So the vitamin D might benefit
it might benefit that, yeah. Even more so as far as for that would be getting some light if you can. And you can even buy lights that you can set up at your desk that shine at you and that can help brighten your day.
Which all sounds very good. It'd be very helpful. So as far as, I know Dr. Holm is a big advocate of vitamin D.
Yeah.
Because in the past few years, they've shown so many different diseases that can come about because of a lack of vitamin D. And there's no way for us to know there's a lack without a screening, right?
Yeah.
Back to screenings.
Right. And you know, some end up needing to do 50,000 international units in prescription strength vitamin D. And so that's where that blood test can help decide if we perhaps need to do that. But
Okay. Very good.
Yeah. Kelsey, do you have anything you'd like to add? What are you planning? What year are you? What are you planning going into?
I am a fourth year medical student, and I am just finishing up my interviews for general surgery. So I'll be entering the surgery field.
Oh, a surgeon. Well, that's very interesting. Do you have any idea which surgery or
I'd like
what
to go into
specialty?
pediatric surgery, so for
Oh.
children, but you got to get through general surgery first. So
True. Okay.
set my sights on that first.
How many places did you apply for?
Ooh, I applied to over 40,
Wow.
and I interviewed at 15. So
Have you been chosen yet, or does that come up soon?
all in March, there's a big match day where all the fourth year medical students across the nation find out where they will be placed for residency.
It's an exciting time. It truly is. Bob?
Do you like the smell of formaldehyde yet?
Well, just nothing like formaldehyde in the morning with a cup of coffee.
That's right. Yep. That nurse shark and pig embryo, whatever they have to start off with, right?
That's
Anatomy and
right.
Physiology 101. Wish you the best of luck, though.
Thank you very much.
Well, while Kelsey was talking, we had another caller with a question and wanted to know, how do you deal with frostbite? Totally different subject, but it is getting cold out here. If somebody has frostbite, how do you deal with that?
The bottom line with frostbite is prevention, and wearing, gloves and trying to stay warm in the first place. As far as dealing with it, get your hands warmed and see if it looks like that there's good blood flow to the end of your fingers or whatever's frostbit. If you push on it and it turns white and turns red again, that looks like it's probably getting some good blood flow. If not, then you probably better come into the doctor and have it looked at.
Okay, and if your kids come in, you've had gloves on them, but they
Yeah.
come in and their fingers they say they hurt, then just keep rubbing it to keep them
Yeah,
warm? Is
keep
that what
them
you
warm.
suggest?
Yeah.
Okay, and they should be okay. Kids are pretty
Yeah.
tough. Yeah,
Yeah.
they do. You probably don't run into that too much because people are so aware of it that they pretty well take care of their kids and
Right.
themselves, and they know what to do.
Yeah.
Well, this has been really interesting, Dr. Ellsworth. We're so happy to have you with us today. We are running out of time, but we hope you've enjoyed our Prairie Doc radio program. As always, you can hear more from Dr. Holm online at prairiedoc.org, where you may also learn more about the exciting activities of the Healing Words Foundation. Tomorrow evening at 7 o'clock on South Dakota Public Television, On Call with the Prairie Doc will discuss how to deal with congestion. This live program will be hosted by Dr. Holm's good friend and fellow physician, Dr. Tom Luzier of the Aberdeen Asthma and Allergy Clinic. My thanks to you, Dr. Ellsworth, for joining me today.
Thank you for having me, Joe.
Okay, and thanks to all of you for listening to Prairie Doc Radio. I'll close with Dr. Holm's weekly reminder, stay healthy out there, people.
Good.